We're live.
Good morning, everybody. This is Jim Hoffman from EMS Office Hours, and I'm with Josh Knapp right there.
Dave Brenner. There's Dave.
And here I am. Yep, Dave
There's
Brenner.
Dave Brenner. Guys, thanks for jumping in. This is, I think this is, I don't know, this is the first time I think the three of us have been using this platform together. I know I've used it with Josh.
I've never been here
Might be the
before.
first time using it. I don't know. I don't remember all three heads.
I've never been on this format.
Yeah, I didn't think so. That's all right. It's easy enough. Well, everyone joining, thanks for popping in. Be sure to hit the like button below. Let us know you're watching. Keeps the feed up. Lets other people know that we are being joined here. And let's keep the feed up in all of the Facebook sites and YouTube and stuff like that. So what I wanted to talk about today, guys, is well, I guess in some ways it's talking a little bit about COVID, but I wanted to talk about and ask the question: does the COVID situation end up pushing EMS forward? Josh, you got to put your headphones in or something because I can hear my voice in the background there. Again.
Well, let me see.
See how Dave has headphones in? Look at Dave. See? He's
If you
prepared.
didn't use these, it wasn't doing that before.
I know, but you left and came back for some reason. I don't know what happened. But I wanted to talk
I
about
still
this
can't
stuff.
see it, Jim.
All right, don't worry
You're
about
not
me.
on my screen.
All right, well, I see everybody. So
All right.
the reason why I wanted to talk about this, because I've been seeing stuff. I was talking to Dave before the show started that I've been seeing a lot of Facebook groups and postings and stuff about EMTs and paramedics. Now they're involved in the vaccine administration. They're involved in the ER overflows. They're involved with mobile units that are getting set up outside of ERs for for ED overflows and stuff and triage. And also now they're being asked to volunteer to work with the whole social worker thing where they're not going to send police to the psych job. They're going to send a social worker, and they're asking, EMTs to volunteer to go with the social worker if the determination is made that the patient needs to be transported to the hospital. So the question I'm asking is this sort of a way that EMS is sort of being pushed forward, with more responsibilities, different sort of sub job titles like flight medic and interfacility transport and things like that, critical care, you know what I mean? So is this something you guys think might be evolving?
So the question is, Jim, is EMS being pushed forward, or is all basically how we approach the service of medicine changing?
Well, I don't know.
That
I
would
mean,
get you, Dave. But
What?
I don't know if it's the I guess in a way it's a service, right? Because it's what we're doing. We're getting it's sort of like off of the ambulance and in different roles, kind of filling
so change the focus a little
empty
bit.
spots. Those filling those empty spots that need to be filled because there's not enough staff in hospitals to handle some of these areas in the country that are overwhelmed with patients.
Okay.
So when you say are pushed forward, are you suggesting that we're being pushed forward professionally or financially, or should they be joined?
I don't. Well, that's the funny thing. Like of course, most of the discussions that I see when people are talking about this, the biggest question that people ask is there a bump in pay if I do this? If I volunteer to go with the social worker, am I getting some sort of financial incentive to do that? It's outside the job that I signed up for. It's outside being on the ambulance. It's another role. It's going to be more, most of those jobs, they also state that There's going to be some training involved for you to go ahead and go with the social worker and what your role is going to be. So people say, well, okay, now I get this extra training. I'm getting this extra stuff happening. Am I going to get some sort of a raise, or at least in that role, will I get a couple of bucks more per hour because while I'm doing that, that job?
I think I understand what you're saying. You're saying, look, we're asked to we're again in that situation where we're being asked to do more for the same amount of pay. And in some respects, the whole look in terms of how medicine is delivered, the whole world has been put on its ear with the pandemic. There's no doubt about that. And there are aspects that we're looking at, or like I'm part of some sort of team. We're not. What I've read is what is being looked at is the resources needed to deliver. And it's sort of a little bit like how manufacturing was looking at the shift in technology 20 years ago.
Right.
We were, at that point in time, the concept of flex manufacturing, just on time delivery, all these concepts of saying, how do we get, product from the raw materials to the consumer. And essentially that same argument is being faced with medical care today. We are in many places still, and we were in some places overwhelmed. I mean, our manufacturing line, our medical distribution abilities basically were on a first come first serve basis. Make an appointment, and it was geared to a fairly low use. If you consider that, I don't know, what do they say today? 50 million Americans are uninsured. One of the arguments, and I'm going to go tangent a little bit here. One of the arguments about healthcare and universal healthcare is, oh my God, we're not going to be able to pay for it and stuff. It's like, guys, we can't pay for the medicine we get now because we're pricing ourselves out of the market. It's a little bit of it comes down to volume, so we get a greater need in place. God, I'm straying. We get a greater need in place, and we create the system that addresses that need. We were never there to start with. So when we had this, where you had the EDs overwhelmed, with
Jim is going to come right through the screen here.
I can't see him.
We're talking about the EMS stuff.
Yeah, I think we went down. You went tangential immediately.
Yeah, I mean, I know you want to get into the whole how horrible the healthcare system is, Josh. But let's
talk
about
it's
I
not.
want to talk about the EMS part of it, and are EMTs and paramedics either benefiting from this by getting opportunities for other things, or are they getting screwed because they're not getting paid?
Everybody's getting screwed. Well, there's your short answer. Everybody's getting screwed.
I'd like to address it differently. Well, we could listen. If we were on the same page, there'd be not much of a discussion. I would say what he said, but I'm not going to say what he said. I think, first of all, in the course of a week, we put in the same number of hours for our base salary. EMS changes, it continues to change, it always changes. Listen, if a new cardiac technique comes out for a surgeon, do they say, well, I have to get a raise because I'm here long, because you asked me to do something new? As a matter of fact, they welcome something new. because it's something new to the benefit of their patients. And I think as a profession that complains, we need to welcome new things, new skills into our repertoire. Listen, if we do nothing, if we always do what we've always done, and expect to have a change in the way people perceive us, that's not going to happen. I think that if we go out on calls for mental health, if we provide vaccinations, I think providing vaccinations is something we need to do. I think we need to, first of all, it's not the first time EMS has been delivering vaccinations. But if we're out on the street, if we show up in a mobile ambulance or a regular ambulance that is simply not serving somebody in an emergency, either at time because it's not scheduled to be out on there, or they're between calls in a place where they actually have between call time, and they can go in and provide a family, a household, a community center, a family or a household probably better, with some vaccinations and document it and get it into the system. I think we become a resource to people. They see it proactive. They see us in a professional light doing the things that other health professionals do. I think if we ever get to the point, because we're not there yet, we need to get to the point where we can call upon the public to also provide support for us. I think the public likes who we are, but the more we can bring ourselves into the public eye as providers, not just in a crisis, but as an ongoing basis, that we can point to it, it builds our professional repertoire, and it's going to lead into whether or not we're providing vaccines or social support to a psychiatric crisis, or medical support to a psychiatric crisis or a social crisis. I think we look better. We get to be able to point to ourselves and say we are better. I don't want to go down. I don't, because I know it just falls flat. I think, education is an important thing. I just think that if we try and nickel or dime, this is a nickel and dime way to get there. Do I think we're ever going to get raises for this? Nah, I don't think we're going to get raises for providing. I don't think we're going to get raises for providing social, support at a behavioral emergency.
No, we're going to get criticized for that. Because who the hell are we going to a behavior emergency when we're not trained? In the same way the cops are getting criticized.
I am fully trained to go to a behavioral emergency. I don't know who trained you. Maybe you should take the PTEP course.
So you have your doctorate. You have your doctorate or master's in psychology.
You know what? I'm not a physician. I am not a physician.
But
no,
that's the level that the criticism will come down on.
Absolutely
incorrect. Exact same thing. You're going out with a social worker. The reason you're going out with a social worker is that social worker brings certain verified skills to the table that you don't.
Yes.
Now you're saying, well, I'm trained to deal with behavioral emergencies. Yeah, we are.
I am. By the way, I'm going to ask you a question. In your original EMT class, I want you to tell me how many hours they spent training you on behavioral emergencies.
Ask me
honestly.
Ask me how many hours they trained me on most stuff.
Nope. I'm asking you this specific question.
It's the
how many hours was your psych emergency class?
The exact same thing as no, actually, maybe
less.
Maybe 15
It was
minutes.
Combined with another.
Maybe 15 minutes more on documentation.
Okay, so they undertrained you in that. They undertrained us.
They undertrained everybody. Look at just PTSD. Look at critical incident stress situations.
You do understand. You understand. I'm one of the authors of the psychological trauma and EMS patients curriculum, right?
In New York?
Not internationally.
No, I haven't heard that. I know that you were in New York.
I'm one of the authors of the NAEMT PTEP class, Psychological Traumas and EMS Emergencies. And I'm going to tell you that taking that 8-hour class, which is tip of the iceberg on the amount of material we developed, is something that every EMT, every nurse should take, because it's an invaluable class for dealing with the psychological stress of patients, and whether their stress is from a cardiac event or a psychiatric event. It is a great course, and we were undertrained in it. But having said that, I don't think it's going to get us a raise. I think it may get us more professional respect. all the little things we've added have never brought us anywhere near the parity of financially of the people we want parity with. Not AEDs, not pushing Narcan up a nose for an EMT. None of that stuff has done anything to provide any relative parity with the firefighting and police services or nursing services.
But what has
So
it done? So Dave, so let me just
it has
refocus
made
here.
us better
What has it
providers.
done?
I'm a better provider. I
Right.
am a better care provider for those experiencing an emergency.
Okay, so behind you are 10 other guys that have either the same interests or different interests or different needs. You know, putting food on the table in a more acute fashion. Then you know you have to rely.
I'm not
You're
saying
fairly
we don't
significant.
deserve more. I've never said we don't deserve
I'm
more.
not saying even that. I'm saying what's going to happen. What happens when a system breaks? What happens? They look at it, they analyze it, and sometimes they limp along with the system as it is. Sometimes they go and fix it. I think there is a worldwide consensus that the way we deliver medicine is not working to our needs now in this generation, and that's going to change. And if you think that change is not coming down the line to everybody who touches a patient, I don't care if you're EMS, I don't care if you're an emergency room tech, I don't care if you're a radiologist. Everybody who touches a patient is going to change, and
You know,
that
we
delivery
normally just
model is
talk
going
for
to change.
about an hour, and if we don't narrow the focus to the things we do, as opposed to the entire failure of the healthcare system nationally here, I think we're in trouble. I mean, listen, I'm not disagreeing with you. I would love to have that conversation another time, but
My thing is, Dave, I agree with you when you said earlier about we should be welcoming additional training, additional responsibilities, uh, and not necessarily looking for an increase in pay every time that happens. But at the same time, you know, people get involved in EMS to become a paramedic, you know, an EMT, and I think most of them soon realize the workload is much higher than what they thought was going to be. The responsibilities are much higher, and then when you're adding more on top of it without allowing for either uh, increased time to do your job, where most agencies pressure you to get on the scene, off the scene right away, in and out of the hospital right away, back in the ambulance, ready to respond to another call. So when you're adding all these new responsibilities in patient care and clinical assessments and things like that, you're not allowed. There's no um, increase with anything else in the job, whether it's money or just understanding what the job involves, to give people more time to do these things that you're expecting of them. And at the same time, you can look at other professions and say, okay, well, I'm working at McDonald's and I'm on the fries, and now all of a sudden I'm getting, you know, put in charge of other, you know, skills within the establishment, but I'm not getting a raise. But this other guy who's been doing it, he got a raise, you
Well,
know,
that's a
because
but that's a really good
he's become a supervisor or whatever. So
it's a
there's
really good
more
example, Jim.
responsibilities.
It's a really good example because when you're at McDonald's and you're on fries and now you're going to be broiling burgers, so you're learning another skill, you're at McDonald's, your pay goes up. You know, when you're on an assembly line or you're in a factory and you're doing a certain skill and you add another skill, that's a reason to pay you
Yeah,
more.
I mean, I know
So the
there's
argument comes back, well, we're learning more skills in EMS. Why aren't they paying us more? And what I'm basically saying is the entire delivery model is going to change in medicine. And, you know, that argument of we're going to be learning more skills, why don't they pay us more, is not going to be connected anymore. We're going to learn more skills. We have to. Medicine is going to demand it. We're
sure.
going to need more flexibility in how we deliver our, you know, those skills. But in the end, what's going to determine our pay within the medical community is going to be the medical community valuing what we do.
Yeah, I mean, I can see that getting more, I guess recognition of what we do and the important role that we have. But then, like I said, you get the argument everywhere where it's okay. Well, now we're being abused, right? It's like, okay, let's use these lower paid professionals that can do the job that the higher paid professionals can do. Let's plug them into those areas, not give them any sort of financial incentive, and then expect them, to keep doing it without any sort of recognition on it. You know what I mean? So it,
Hmm.
it 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 gets to that point, I think, where I understand what Dave is saying, right? That balance of saying, okay, we're going to get this additional training. We shouldn't really look for more money because we should be welcoming it because it's going to elevate us as a profession or whatever. But there has to be a point where they say, okay, maybe every 5 things they add, we get a little bit more money. You know,
And
as you
I
said,
think what
like the fries and broiler thing, right? They get a bump. I know of a grocery store where when you get a job at this grocery store, no matter what your qualifications are, for the most part, you start at bagging, right? You don't
Mhm.
get to go anyplace until you've done the bagging part of the job for a while, and then you get to another position, whether it's the cash register or whatever, and then you get a raise. It's like
Mhm.
you're not a bagger, and then you learn how to do the cash register, and you don't get a little bit of a bump in pay.
Did Dave drop off your screen too?
Yeah, he's gonna have to come back in, I guess.
All right. I understand. I get the argument that both you and Dave are making in terms of, Dave is saying, well, we're going to get these more skills, and here it comes.
Yeah, Dave's
And
coming.
and you're saying, well, we get more skills. Shouldn't we be paid for it? And the answer to both those questions is yeah. Hey, Dave. I was just saying that, I agree with your argument. I even
So I
agree with
see me. Are
Jim's.
you guys in?
You there?
Yeah, we got you.
Okay. I agree with your argument, Dave. And I even agree with Jim's. But what I'm basically saying is that argument has been the same argument that that we as a group have been discussing for almost a decade, has been the argument for EMS for 30 years. I mean, ever since I came into it, it was a long time, an old argument. And what I'm saying is that what will change EMS for us is the the requirement in the community, uh, that they need our services, nothing else, absolutely nothing else, because there's going to be a point when you just can't pay somebody to do this job, and then that's where the pay will come when they have to.
Yeah. I mean,
But what
listen.
I'm saying is, but there's the light at the end of the tunnel, and it's where I sort of uh, uh, tangentially went before, is the idea that medicine is going to change in how it's delivered. There's this entire aspect that has, they I'm trying to remember what they there's this entire aspect of where you upset the apple cart. um I'm reading this. There's too many distractions here. And Dave, you're frozen. Are you frozen? You
Yeah, I
froze
think
again.
Dave is frozen.
God, I love this platform.
Can you hear me?
We can hear you, and you're
Yeah, we
moving
got you,
again.
Dave.
Life. But there's until that these requirements are demanded by the
Yeah.
community, our pay won't go up.
Yeah.
That's the bottom line.
Oh, Dave's trying to get in. He must be having a slower connection for some reason today. That's all right. He'll pop back in and be live in a second, I'm sure.
Hmm.
Listen, I get what you're saying, Josh, and I know, like you said earlier, that we've been banging this drum about more pay since we've started this podcast, you know, 10, 15 years ago. You know what I mean?
Hmm.
Um, and not much has changed. I mean, I was going to mention about increase in pay. We have these community paramedicine, paramedic units, and they are being called upon to do a lot of the stuff that we're talking about. And those guys are already making a little bit more as community paramedics. Those guys have more, they usually go through a training process, they have more responsibility, and they're making house calls, to
Hmm.
keep people from going to the ER. And, and they're getting paid more, and they're being called upon for a lot of the stuff that we're talking about, as far as either giving vaccines, whether it's preventing them from calling 911 to go to the ER for something. So you get those guys that are getting some more recognition, and I think in the healthcare realm, like doctors and nurses see them, I think, a little bit more differently than they see the EMT bringing the drunk into the ER for whatever
Right.
reason. You know what I
Right.
mean? Because they think, oh, they've had more training. They're different than the regular medic that's out in the field, but their training isn't really in addition to what you're doing as an emergency provider. It's just what you're doing as a more of a non-emergent provider. You know
Well,
what I
it's
mean?
also the connection that you're sharing with the physician or nurse, or whatever title that you report to as a community paramedic.
Yeah,
There's that the aspect that you're talking about an individual patient with different issues and different challenges, and you're addressing those in medical terminology. So you're giving an interface, whereas the EMT who brings in the car crash victim, basically is almost like a game of hot potato, where you're bringing the person into the emergency room. You're not bringing a ton of valuable information that the doctor knows, because you don't know. You don't.
right.
You may have talk to somebody at the scene, or you may not have, and then is it a drunk in the car? Is it a drunk in a car with a heart condition? Is it drunk in a car with diabetes? Are they,
Sure.
what other things are going on? Where when you come in and you're servicing a patient in the community paramedic or the traveling nurse scenario, you have a much closer and more a more educated approach uh, to the patient and the patient care that you are talking with that doctor about. Now that doctor is going to get a whole different picture from you than you're running in, and you're instead of 5 minutes, you now have 25 minutes
Yeah.
of
Well, that's what I was talking about before Dave
information.
got cut out, right?
Right.
Is that mentality of, we have all these additional responsibilities, but now we're expected to still perform all of these in the same time frame, right? Like you said, 5 minutes versus 25 minutes. So if you got the additional training and no additional responsibilities, and now you've got someone, you're not in a big rush necessarily to interact with your patient, or in a rush to interact with doctors and nurses. You're I think we get, honestly, I think we get seen as more professional when we're able to take the time and show that we know what the hell we're talking about.
I agree.
Versus, oh, here's the body, here's my report, sign here, I got to get back out, dispatchers holding a job for me. You know what I
Right.
mean?
Yep.
So that's, I think, the biggest, thing on that. You know what I mean?
In term, well, no, clarify that a little bit. The
Well, I think
biggest thing.
one of the biggest things, if we're not going to, like I had said earlier, if we're not going to necessarily get paid more for every skill or every responsibility added to our, sort of, queue, um, we should at least be given the extra time to do the job thoroughly, and to do it in a way that is professional, and not feel like it's something else on the plate that we got to squeeze in to the required 20-minute on scene time or the required 20 minutes in the ED time. You know what I
Right.
mean?
Right.
So sure, give me more responsibility. I can kind of take that to a point without having a financial gain with that, as long as you're giving me. I don't want. I guess I want to say respect. Give me
Yeah,
that
but
respect.
you're
You know.
why is that 20 minutes on scene time? Why is that? Why do we have those limits based on how we and I wish Dave was here because he would have these stats. But
Yeah,
why
he's
why are
trying to
we
get in.
being judged on these seemingly random time periods? And I propose it has nothing to do with the medicine that we're delivering. It's
No, it has to
it's a
do with
look on.
getting us in this our asses in the seat so that we can, you know, you know what I mean, so that we can
No, I
have
understand
another
completely.
call.
But because what they have basically done is they what the people in charge, they basically said, listen, our medicine is limited. What we can do for the patient is limited, and therefore we need to categorize you as in this employment structure where you need to do more work for what we're paying you so we can squeeze out of the budget more jobs in the end. But that's it. Now, when I was critical care, once I went on a job and I had a discussion with the dispatcher about this, I was like, I don't hear anything from you guys. And he said, "You're critical care, dude. When you get on the scene, it's you. We assume that you're doing whatever you need to do, and the technical difficulties of the job determine how long you're on there."
Right,
And it's like,
they're not asking you for updates on the radio
no,
and stuff
no,
like that.
no, because you're trying to figure out 10 pumps and what medicines go with what, and making sure, because and here's some of the craziness is that you're responsible. You bring back somebody and they're on the wrong dosage of a drug, you're responsible for that.
Right. Right.
So now and critical care medics are still paramedics. They get paid a little bit more than paramedics do, but not 2-3 times what a paramedic does.
Yeah. Well, the same
Where a
thing with
nurse, her
flight
first
meds, right?
year
Flight
coming
meds
in,
get paid more than you know.
but
Uh,
look at a nurse, Jim. We've had these discussions. Look at what a nurse comes in and gets on the job, and
yeah.
then what's their ceiling compared to it?
Right.
Hey there,
Hi.
boy, you're having some issues out
I'm
there on
having
the
issues
island.
today for some reason.
There's someone.
Yeah.
It's not common to
Yeah.
hear
He's
me.
underwater.
Barely. You're underwater, and it seems like you don't have the throughput. Screen is freezing constantly.
Oh yeah, you're telling me. How
Yeah,
about now? You hear me better?
A little
same.
bit.
And I don't need to be ridiculous.
I'm not sure what's going on with Dave today.
I don't know. You.
Yeah. Well, listen. Well, let's cut it there because Dave's having an issue getting back in, and I don't want him to keep struggling trying to
Right.
get back in here. So, but
I don't need-
once again, we this show is not going to give you the answers, right, Josh? We always say that this is office hours because the idea is that we come on here and kind of throw out these questions, these conversations, and hopefully people watching it will continue the conversation with people they know, ask the same question with people that they know to try to see what kind of different answers they get or similar answers, and
Yes.
and hopefully that moves us in a direction as well, right?
You
That we
know,
start thinking about that.
I do want to add one aspect to what you're saying is that keep in mind for the people who are watching and thinking about these issues, a tsunami of change is coming to medicine. This pandemic has exposed cracks and breaks in the system. Is also exposed ideas that, oh, you can't do medicine over the phone. You can't do medicine by
Yeah,
video.
that's
Oh,
increased, right? How much has that
I,
increased? I mean, there are EMS agencies now that will suggest that if the patient is low risk and whatever, that you call the teledoctor and keep them at home.
right, right.
You know,
And they're looking at the flexibility of you don't have to go through 2 years of nursing school in order to give an injection.
right?
I mean, that was down to the EMTs. Look at in New York State, camp counselors were allowed to give EpiPens before EMTs.
Yeah,
So it's a way that medicine is looking at itself now, is what I keep on referring back to. I don't think before medicine was looking at itself. They were all looking at how do we squeeze more money out of each individual step. Now they're looking at, do we need those individual people in those individual steps? Can we take this whole thing and place it on its head and use people that we never thought of before? If you're a transport medic and familiar with vents, why not work in an ICU where every patient is vented and the nurses, they're overloaded for how much they can
yeah.
deliver. But if you go and you work vents in an ICU, are you going to be wanting to be paid the same amount as on a transport rig? I think they're going to have to. I think medicine is going to have to start valuing the people who are contributing.
Yeah, I mean, listen, I agree with you that I think that things are changing, and again, we can go back to the original question of, okay, things are changing. Is that going to mean more, just more responsibility for everybody, not just EMS? For nurses and lab techs and all that type of stuff as well, or is it going to be some more responsibility and more money because of the fact that the roles are changing, responsibilities are changing, the way we interact with patients is going to be changing, and we have to be trained in that, in
Hmm.
order to do that. It's not going to be, okay, here you go, Josh, go down the road now. Now you're gonna automatically, you're gonna interact with patients that you never encountered before. You're gonna be responsible for certain levels of care you're never
I
responsible
think with
for.
the
You
examination,
know,
Jim, there will be more money. In my humble opinion.
I think eventually it will, and I just think, like I said, I don't know how soon that's going to happen because, as you know, for most places, we end up being just the asses in the seat. Get out there, get the calls done, don't kill anybody, you know,
Hmm.
and just go home safe,
Right.
versus the fact that, okay, we are, as an EMS, as someone that's at the top, okay, we're an EMS agency, and these are the new responsibilities that we have. These are the, the how we can step up and fill voids and step up and help the overwhelm of the system at times.
Right.
And I
Right.
think that is coming, and a lot of places is already here. The community paramedics, nigga, the big one. I know agency where they have a form where you go into old, elderly people's homes, that you're filling out a form, or doing an evaluate for non-critical patients where you're evaluating fall hazards and trying to educate them on fall hazards in their home.
Sure.
You
Yep.
know what I mean? This is a sort of like an added thing. But again, that goes back to my other argument of, okay, if we're going to do that, that's great. I'm on board for that, right? You're going to avoid a person getting injured or whatever. But where's the extra time I'm being allotted on scene to do that evaluation and educate the patient? You know?
Well, but that's then we start down that path of you know, what's the difference between a visiting nurse and a
Sure.
community paramedic?
Sure.
You know,
Well,
because
that's the
that's
whole
the
thing too,
exact
right?
same
That's another
job.
argument as well that we've talked about in the past too, is that when will other you know, healthcare entities like nursing, PAs step in and say, wait a minute, why are we letting paramedics do these jobs when we could be doing these jobs and getting paid for it? Why are we letting
Right,
them getting paid for it? You
right,
know? So
right.
Josh, let's end it there, man. David
Okay.
will not be joining us again. He's having some issues with his video and audio, so I'm sorry he couldn't jump in. I'm sure he had some
Mm.
good comments to make. So uh hopefully next time we'll hammer that out. But I think most of the time it's on the user end where the video issue is. If it was on our end, I think we'd be more aware of it with
You
you
would have
guys. So
fixed it by now?
yeah, I think so. I think so. So all right. So guys, please do me a favor, hit the like button, leave some comments. Thank you everyone that's in the chat room that's been leaving some comments and some chats there. Mohammed, I see your question, brother, but just we can't really get into that right now. As far as the differences between USA, Canada, Australia, EMS, I don't know enough of it to really answer that question.
Well, we've
Um,
done some shows in the past that have both had guests and have
yeah,
talked about, you know, some of the differences.
yeah. I think
And
that the goal for you, Mohammed, really would be to try to figure out where you want to be a medic. I know you say you're a medic in Saudi Arabia and you want to do it someplace else. So my suggestion would be to find out what country you want to do that in and then focus on the requirement for that country so you're not all over the place and getting confused as requirements from one to another because every country is going to be, I'm pretty sure, entirely different than the next. So, all right, Josh, thanks, man, for popping
always,
in. I appreciate it. Everyone, like I said, leave comments. Go to EMSofficehours.com for previous episodes, and go check out oxygenwrench.com for an amazing oxygen wrench, and go to emssco.com/coin for a rare and limited quantity only COVID EMS challenge coin that I'm sure you will enjoy once you get that because it truly is a collector's item that
and
you
it's
don't want to
even more. I mean, you're they're pretty much out of them, aren't you, at this point?
I'm getting there. I'm getting there. All right,
So,
everybody. That's it. As always, I am Jim Hoffman.
Josh Knapp.
Stay safe.